Over to you, Bodun.
Thank you very much for inviting me, Ngozi. First of all, can I just congratulate CAHN? You guys are doing a wonderful job. It's a pleasure to be here, and I'm really pleased to be part of this. As you mentioned, we're beginning to have a lifting of the lockdown regulations, and the people are generally feeling better. And so we're in a slightly better place than we were at the beginning of the pandemic. So as you've mentioned, I'm a general psychiatrist. I work at Ede Center for Mental Health, which I'm a dedicated inpatient consultant. So patients tend to be admitted acutely ill, and we undertake assessments, and then we treat them, and then we discharge them. So that's what I do. So today I'm going to be talking about generally about our mental health, and we're going to be talking about mental health conditions. But the question really is, why are we talking about mental health at the moment? So can I just share my screen? Are you able to see my screen? Are you able to?
Not yet. You just,
okay.
If you share it, that's fine. We will see
share
it now. Excellent. We can see it now.
You can see it now. Fantastic. So the real question is, why are we talking about mental health at the moment? We're in the middle of a pandemic, okay? And we know that some of us have been bereaved. Some of us are currently still grieving. Others have lost jobs. A lot of us are unsure about what's going to happen in the future regarding their job situations. Understandably, this is going to cause a lot of anxiety. People are going to be stressed, and this is going to have an impact on our mental health. We also know that because of the pandemic, certainly in the early days of the pandemic, a lot of the services that are normally available to support people with mental health problems were shut down. We were having to discharge people who were ill from hospital because we considered that it was riskier for them to be in hospital, and we were sending them home. So, and again, these people were not having access to mental health services. But even currently, we know that some of the adaptations that have been made, like online assessment of patients, providing psychological therapies online, are proving to be very difficult for some patients that are struggling with the technology of accessing help online. Yesterday, I was just reading one of the Mind reports where they surveyed about 2,000 of their service users. A quarter of these people said they were finding the online psychological therapies extremely difficult to deal with. And a third actually said it was making their mental health worse. So these are the challenges that we're currently facing as a result of the pandemic. Before the pandemic, we knew that 1 in 4 people would suffer a mental health problem during their lifetime. We are currently still collecting data, but we do know that the rate of depression has increased across all age groups as a result of the pandemic, and that is a fact. What are the risks when somebody has a mental health problem? We know that 90% of suicides occur as a result of mental disorder, either depression or schizophrenia. For instance, we've got data that in 2018, 6,154 completed suicides occurred. Out of the, that's an average of more than 16 people took their own life in 2018. We know that men aged between the age of 40 to 49 have the highest rates of suicide. So they don't mess around in that age group. No, suicide is the most common cause of death in the 10 to 19-year-olds. And we know also that people with mental disorder are twice as likely to lose their job every year, not to talk of the impact on relationships, on family life, the breakdown of relationship and all of that. Males have a slightly higher risk of schizophrenia. And again, this is a statistic that we've always, I think most of us must have heard before. Black Caribbean are 7 times more likely to be diagnosed with psychosis and more likely to have experienced psychosis in the last year. Again, that is data that Adult Psychiatric Morbidity Survey. So these are the reasons why we need to talk about our mental health. I mean, I could go on and on and on, giving us very shocking statistics. But it's important to pay attention to our mental health. The next slide I'm putting up this slide. The terms look very similar, mental health and mental disorder. And these are terms that we sometimes interchangeably use because they have similar, they appear similar, and sometimes we use them one for the other, but in reality, they're slightly different. Having a good mental health is a state of well-being in which an individual attains their full potential. They're able to cope with day-to-day stresses. They're able to work productively and able to contribute to their community. It is not simply an absence of mental disorder. So for someone to be in good mental health or in poor mental health, they don't necessarily have to have a mental disorder. It is a daily it's a feeling that you have on it from day to day. You know, I woke up this morning, I'm feeling good. I'm feeling very positive. I can do things. I can work. I'm very charitable. I can contribute to this. These are the things. So when that happens, we're in a good mental health state. And the more good days that we have, the more healthier our mental health is. On the other hand, a mental disorder is a medical condition which involves changes in our emotions. There is a definite change in how we feel. This is also associated with our thoughts, in how we behave, and how we perceive the world around us. This change, there is a definite start, and usually there's also a definite end. This change is associated with significant personal distress. Usually the individual might be crying a lot, they might appear extremely irritable, they might appear a lot more angry. Usually it is associated with a significant loss of functioning, either in social settings, at work, in family life, or even at school. To diagnose a mental disorder, it needs to be done through a psychiatric assessment, and it will require medical treatment. To improve mental health generally, without a mental disorder, these are the key things that needs to happen. One needs to have a healthy lifestyle, maintain a positive attitude to life. Generally, you have to value yourself. You have to devote time. You have to pay attention to yourself because you're a valuable person. You have to consider yourself. You have to care for yourself. You have to engage in things that you know would generally make you feel happy. That is you taking care of yourself. Exercise regularly. Again, it doesn't have to be jogging. There are several ways in which one can maintain physical exercises. Ensure that the individual sleeps well, ensure that they eat well, and maintain social connections. That is important to maintain a healthy mental health state. Keeping in touch with friends, family. Now, occasionally there may be stresses. Occasionally you may be struggling because someone is upset or something's happened. Again, one can access what we call talking therapies. Again, this is something that you don't necessarily need to see your GP for. You don't have to see a doctor for it. You can just self-refer. And each region has their own talking therapies. It's free. It is actually called IAPT, which is improving access to psychological therapies. Again, you don't have to have a formal diagnosis of a mental disorder for this to occur. On the other hand, if somebody has a mental disorder and they've been diagnosed with a mental disorder, they will require psychological therapy. In addition to that, they will require physical treatment. This physical treatment may include medication. Very rarely these days, it requires what we call ECT, electroconvulsive therapy. Very rarely. This treatment may occur within hospital setting, or it may occur within the outpatient centers. Occasionally, and very rarely, it may include the use of the Mental Health Act, which is compulsory treatment, because some conditions, the individuals are not aware of their mental illness and the risk associated with it. And under these conditions, they may be made subject to the use of the Mental Health Act. Okay. I've brought this slide just to give a brief classification of mental disorder. This classification is not the full list. This is just for us to just have an idea of what happens when someone is diagnosed with a mental disorder. The first slide, the first at the top of the list is what we call the affective disorders. These are the mood disorders, which is like depression, if somebody has a depressive episode, or a manic episode, or what in general a lot of people would have heard the term bipolar affective disorder. Like a typical example of a psychosis is schizophrenia. Again, this is where the individual experiences what we call delusions, what we can sometimes call hallucinations. And I'm going to go into detail a little bit about those a bit more. Then we have the anxiety disorders, which is panic disorders. Post-traumatic stress disorder is a form of an anxiety disorder. And then we've got the obsessive compulsive disorders. Under the anxiety disorder, we also have the agoraphobia as well. Then we've got the substance misuse disorder, which include alcohol abuse, the use of illicit substances such as cocaine and cannabis. We also have conditions called eating disorders, again, where the individual becomes excessively preoccupied with their weight and what they eat, and they attempt to restrict what they eat in order to maintain a certain body weight, which is below the healthy body weight. Then we've got the bulimia nervosa. These again are conditions where the individual are abnormally preoccupied with how they look, and then engage in inducing vomiting as a result of coping with the distress they have. We've got the personality disorders. These are people who struggle with their mood states and engage in what we call self-harming behavior in an attempt to cope with the distress that they're experiencing. And of course, we've got other forms of personality disorder, including antisocial personality disorder. We've got the organic disorders, which would include the dementia. And I'm aware, I've seen just one of the flyers. I'm aware that there's a talk being prepared sometime this month on dementia, which we'll talk a lot more about that. So, but I think this was just to give you a flavor of the conditions that we tend to diagnose people with mental disorder with. It's a lot more than this. In doing those classification, we use what we call the ICD-10, which is the International Classification of Diseases. Now, the ICD-10 is currently in use and it's been in use for the last 30 years, but it's going to change from the beginning of 2022. They've produced a new version, which is called ICD-11, and there's some slight review of this diagnosis which would occur. Okay, the next slide is to see the changes which I've described earlier, which occurs in the various conditions. So I've got here depression, I've got mania, and I've got psychosis or schizophrenia. These are the changes that would usually occur in each of these conditions. So for instance, if somebody was experiencing a depression, the expected change in their mood would include they will be very, very sad, extremely miserable. Even in situations where we would expect them to be happier, pleasant situations, their mood state doesn't change. They are not able to experience the normal changes that we would experience. If they were experiencing a condition like mania, their mood state would be unusually and abnormally elevated. They will have an increased sense of well-being. And this sometimes can be irritable. They can be extremely irritable as well. And this pattern, this mood change will be visible to everyone to see because it's a definite change from how they would normally have been. And of course, if they were experiencing psychosis, they could have very rapid, unpredictable mood changes. One minute they could be happy, the next minute they'll suddenly start crying. They themselves are very confused about their feelings. They sometimes are happy when they should be sad and they can't understand it. And that is something that can happen in psychosis. With regard to their thoughts, in particular in depression, they tend to see everything in very negative light. Everything is negative. For instance, they see themselves as being a failure and they think the world around them and they see them as they blame themselves about things that have happened in the past, very trivial things that nobody will blame them. They feel responsible, and then they become very preoccupied with negative things that have occurred in the past. Again, unnecessarily, and they start blaming themselves. And because they feel that they are a failure, and because they feel that they have not achieved anything, they start looking to the future with a lot of hopelessness. They feel that nothing is going to work for them, that the same negativity that they've got now will carry them into the future, that their body is going to deteriorate, their business will fail. And it is this pattern of thinking that starts giving them, that leads to this sort of patient beginning to think that there's nothing to live for, and they start experiencing thoughts of life not worth living. And unfortunately, it is this pattern of thinking that inevitably leads to suicidal thoughts. And then they complete suicide, unfortunately. In relation to mania, okay, in mania, the sort of thoughts that these sort of people will be having, the sort of thinking they will be experiencing, usually they are the exact opposite to somebody who is depressed. They start feeling unusually unreasonably optimistic about the future. They start seeing themselves as being extremely grandiose and bigger than what they can achieve. They have what we call self-important ideas. They have all these big ambitions, that things that they want to do. And usually when you start discussing and trying to explain to them that actually this isn't going to happen, this is difficult, they become very angry and sometimes extremely suspicious. And you might find yourself getting into arguments with them. What happens in psychosis is slightly different. If somebody is experiencing a psychosis, they start being extremely anxious for no apparent reason, usually, and then they start getting suspicious. They might start thinking that people around them are inducing their anxiety. They become very guarded. They keep their thoughts to themselves because they don't want to share it. They don't know who is listening. They don't know who is planning, who is working against them. And usually, they might hold beliefs which we call abnormal beliefs, which are held very strongly, despite evidence to the contrary. So you might get someone who believes that perhaps family members are trying to kill them. And there's no evidence to back it up. And when you explore this belief system, you realize that it's not in keeping with their background, their cultural background, and not in keeping with their educational background as well. It just doesn't make sense. Some of the things they say. Again, these sort of people who are experiencing psychosis, their thoughts are so confusing even to them that it's so difficult to get it across to people. So when you're listening to what they say, it doesn't seem to add up and it doesn't make much sense. Again, in depression, if we go back to the depression side, there is no changes in their perception, whereas in psychosis, you can see someone who is experiencing psychosis responding to what we call stimuli. They start behaving a certain way as though people were talking to them. You can see them laughing, even though you can't see why they're laughing. We tend to call that hallucinations. You don't tend to get that in depression unless the depression has become extremely, extremely severe, and it is now complicated by what we call psychotic symptoms. Again, you don't tend to get psychotic symptoms in mania, but you can do so if this mania becomes severe and extremely complicated and the individual is struggling. It can get complicated by psychotic symptoms. What are the behavioral changes that we see in each of these conditions? So, for example, if somebody was depressed, what sort of changes do we notice in their behavior? The first change is that people who are depressed tend to avoid social interactions. They lose enthusiasm for activities that they've previously enjoyed. Their self-care starts deteriorating. They become very lethargic, sometimes extremely restless, can't stay still, constantly pacing back and forth. their sleep is disturbed, they tend to wake up in the early hours and then start ruminating, start thinking, and struggling to go back to sleep. Appetite usually is diminished, and because they are not eating well, they start losing weight. If they were engaged in a particular task, they will struggle to concentrate to complete the task, so they tend to leave task undone. If they were experiencing what we will call mania, usually is the exact opposite of somebody who was depressed. In the case of depression, where they avoid social interaction, manic patient tends to have what we call increased sociability. They become extremely sociable. They have this increased sense of well-being where they feel that they are invisible. They are extremely well, that nothing can touch them. They want to do everything. They're overactive, constantly on the go. In the way they're dressed, they tend to be dressed very brightly colored, sometimes ill-assorted dressing, and they are usually described as being flamboyantly dressed. Because of the overactivity, sometimes they become so physically exhausted that their legs start swelling and they can't move. Again, because they are not able to focus on a particular task, they often leave tasks uncompleted. Usually when speaking to them, they speak very fast, extremely excessively fast, that is difficult to interrupt them. Again, sleep is reduced. They tend to wake up very early in the morning. They might have 2 or 3 hours of sleep, and they will wake up feeling extremely energetic and lively and can't just settle. Appetite is increased, sexual drive is increased, and they engage in behaviors that has no boundary, that socially disinhibited. Again, they engage, if they were engaged in business, if they were business people, they start spending money excessively. They can give up a good job for some sort of risky business ventures and completely lose all their money. In the case of psychosis, what you would usually find is, again, somebody who is experiencing psychosis, they get withdrawn, will avoid social interaction. Sometimes they may appear extremely frightened and confused. They are not sure what's happening to them. And they may get suspicious and think maybe other people are trying to influence them or control them. That dressing may be seen as being bizarre or strange. Their mood state may be extremely unpredictable, as I mentioned earlier. 1 minute they may be crying, the next minute they're laughing, and they themselves are not sure of what's happening. They become less interested in their self-care and will often ask themselves, why should they care or dress properly anyway? And so when we look at them, we see that their grooming tends to have deteriorated. They may be observed talking to themselves or laughing, and we can't understand why that's happening. And they may also appear preoccupied, and their thinking to themselves becomes very difficult, and they can't make sense of this. So it's important to be able to recognize if somebody is experiencing a mental illness or a mental disorder, because these conditions are associated with significant distress for the patient. It tends to be associated with level of risk either to the patient or to people around them. As we mentioned earlier, people with mental disorder do commit suicide. So it's important to be able to recognize it very early on. So the first thing to do if one recognizes a mental illness is to contact the GP. Sometimes this can happen at weekends. We can contact our local A&E. Occasionally, people have been struggling with mental disorder, and they're struggling because the patient doesn't want to go to A&E, or the patient doesn't want to see their GP. Family members can request what we call a mental health act assessment from the local authority. If the worst comes to it and nothing is happening, we can ring 999 and get the emergency services to come. If they feel that there's a risk or they feel that the patient is posing a risk to themselves or to others, we ring 999. We don't have to wait, and the patient will be taken to hospital and may be assessed under the Mental Health Act. Occasionally, and very rarely, Individuals with mental disorder finds themselves in court, and the judge may decide to request a psychiatric evaluation of the individual because they feel that the individual is at risk of vulnerable. So a lot of the patients that we see in hospital, this is how they get referred to us. And a psychiatric assessment would usually take between 45 to 60 minutes. And it would involve the doctors trying to elicit, to obtain a history. And usually it will start off with the presenting complaint. Say, for instance, the patient started withdrawing and stopped eating. The doctor wants to know, when did it start exactly? When did they notice the changes in the person? And then they would then try to track how long this has been going on, what else has been happening, in what other ways has this impacted on the person's life, and what are the risks associated with this? What else could they be? So that is what the doctor will be trying to establish from the history of the presenting complaint and history of from the presenting complaint and history of presenting complaint. Because we know that usually when someone's experiencing a mental illness, there is a risk of a further episode. So we will want to find out if they've had the previous episode, what treatment did they receive, how long did the episode last, what were the risks associated with the previous episode, because sometimes they follow the same pattern. Then we know also that there are some medical conditions which can trigger a mental illness or trigger a mental disorder, such as an underactive thyroid, or in some cases, if somebody is suffering from a condition called Cushing or other conditions. So we want to find this out. We want to find out about the family. And this is important because we know that some conditions run in the family. In particular, psychosis and schizophrenia, this run in families. We also know that mood disorders also run in families. So we want to find this out. Because we know that in some families, relationships can be very abnormal or an impact on people's mental health. It's important to find out the composition of the family. It's important to find out how these different people in the family, how they relate to each other, and what is the current level of support that they're able to provide to each other. Again, this is important. And then, of course, we want to find out if the person is married, what is the impact of the current relationship on their mental health? How is this impacting? Are they going to be able to continue to provide support? The doctor might then want to find out about the patient's personal background. Where was this individual born? How was this person born? We know that some conditions are associated with complications at birth. We know that some conditions are associated with prematurity. Again, the doctor will want to elicit a lot of symptoms relating to this. We know that in some conditions, as it grows, because the doctor wants to know the development of the person. How did they go to normal schooling? Were they brought up by their parents? Were they adopted? Did they go into care? We know that if individuals are adopted or went into the care system, they are more at risk of developing some conditions. So this is important. Again, we want to know about schooling. What was schooling like? Were they abused in school? Were they able to learn? Did they need extra support? Again, this is important in terms of their intellectual abilities. So in terms of the occupational history, this is important because some people might be struggling at work and work might be a source of stress. Again, this is important. We want to find out about whether they smoke, they drink, or they're doing drugs. What is the housing situation? This is important for most of our patients. Some people are living very on deprived conditions. They have no housing, they have no support within those housing, they have no financial support. Again, this is important to be able to understand from the patient's perspective. And of course, we want to know if this individual has had problems with the law. Again, this relates mostly for people with personality disorders, or sometimes with people with schizophrenia or people who have committed significant offenses. So again, it's important to know premorbid personality. At the time of contact with service, we know that this person's behavior has been influenced heavily by their mental health condition. But it's important to understand how they were before they became ill. Are they usually extroverted? Are they usually introverted? Are these people generally easy to work with? Are they pleasant people? What sort of leisure activities do they engage in? So this will help to tell us, compared to how they are now, how severe is their illness. So, although at the time of access, we need to, the mental state examination tells us exactly how the patient presents at the time when he's being seen by the doctor. So the doctor will need to comment on how the patient presents in terms of their appearance, in terms of their dressing, in terms of how they're engaging within the assessment itself. In terms of how the person is interacting with the doctor, is it hostile? Some people don't want to come to hospital. Some people are being forced to come. And under those conditions, they present extremely irritable, extremely hostile. Again, the doctor will examine their speech, looking at how it flows, the tone of their speech, structure of the speech. Are the ideas connecting well with each other, or are they jumping from topic to topic? Is there any real connections in the ideas that they're expressing? Does it even make sense? Are these people talking spontaneously? Do they need to be prompted? Or are they just quiet? So all of this will have a bearing in terms of the doctor making a diagnosis, because in each condition, it is different. Again, the doctor will then will assess how the person is presenting within the meeting itself. Is this person angry? Is this person depressed? Is he looking flat, very unhappy and very sad? Or is this person looking very happy? Why is this person happy when they're being assessed under the mental? Why are they when they're being assessed under the mental health act? That doesn't correlate very well. So the doctor will make a note of all this. The doctor will then assess their thought content by asking them specific questions regarding what they're thinking. We want to know exactly what they believe, their belief systems relate to. Does it make sense what they believe? Is it abnormal? Does it make sense that they think they haven't achieved anything, even though there's evidence to prove that actually they are very successful in their life? Again, this will give the doctor an indication of what the diagnosis should be. The doctor will make a quick assessment of their perception. Are they experiencing what we call hallucinations? Can they hear people talking to them even though there's no one around them? Can they see things that other people don't seem able to see? Again, this is very important. And we will then do what we call a cognitive function assessment. What is their memory like? What's their concentration like? Are they able to retain information? Are they able to process information? Once all of this is done, the doctor will then assess their understanding of what's happening to them. We tend to call this insight. The doctor wants to know, do they recognize that they're poorly? Do they recognize why people are worried about them? Do they recognize the risk that they may pose to themselves or the risk they pose to other people? Do they even accept that they are ill? Will they accept treatment? Will they accept support if it's offered to them? So all of this is important. So after the assessment, the doctor will undertake what is called a formulation. A formulation is simply a document which will have a diagnosis with reasons. It will then give the doctor will then speculate on what he thinks might be responsible for this person becoming unwell at this time. This would include what the doctor thinks may have predisposed the individual to this mental disorder. This could simply be somebody who had a very difficult upbringing, or somebody who went into care and they couldn't settle into care. What is precipitating this condition at this moment? We know that usually when individuals suffer from mental health problems, there's something that tends to trigger it. Again, this could be adverse life events. Again, what are the risks? This person could be experiencing suicidal thoughts. This person may be incorporating people who they think are planning to kill them into their delusional system and planning to attack them. Again, the doctor will need to elicit this from the conversation with the patient. And of course, there will be the risk that the mental health may get worse if they don't receive treatment. All of this, the doctor will make a decision around this. And when there may be further investigation, for instance, if the doctor wanted to speak to family members, the doctor wanting to speak to the GPs, may even want to contact the school just to obtain additional information. When all of this is done, we will then undertake a physical examination of the patient, because we are aware that some physical condition may be responsible for the mental health problems that the patient is experiencing. So we do all the routine bloods and we will do ECG just to check the heart, how is the heart functioning and all of that. Once we've done this, in some cases, we may order what we call CT scans or MRI scans, just to have a picture of how the brain is. Again, this is to help our diagnosis. So once the assessment is completed, the doctor has to decide, can this patient be managed at home or can this patient need to come into hospital? This decision is usually based on the urgency of care. If the patient is extremely vulnerable, if there are significant risk, and the patient can no longer be managed safely in the community, a decision will be made to admit the patient. On the other hand, there are several people with mental health problems who are managed in the community. In most cases, they are managed by their GPs and never have to come into hospital or see secondary care services. Again, this is because the risk is low and family people can support such individuals. But that decision will be made by the doctor who is undertaking the assessment. Again, a decision will need to be made in terms of whether medication versus talking therapy. Talking therapy, as I mentioned earlier, is easily available, is free on the NHS, and you don't have to see your GP to be able to access talking therapy. It will just be a case of ringing, and the individual will be seen within 6 weeks. But in some cases, in severe cases, the patient may require treatment. And this treatment usually is antidepressants, antipsychotics, or mood stabilizers. Again, the basis for treatment is because we know that when individuals experience a psychosis, for instance, it's a temporary abnormality of the normal functioning of the brain. And we know that the brain interacts with each other or communicate with each other through chemicals called dopamine or serotonin. These are chemicals that the brain uses to communicate with each other. And the medication that are prescribed, they are based on this theory that during a psychosis, there's either excessive amount of these chemicals or a reduction in the amount of this chemical, or this chemical are simply just behaving abnormally. So the medication that are prescribed is to either increase these chemicals in the brain or to block some of these chemicals. And that is the basis for medication. Again, as I mentioned earlier, some patients are not aware that they have a mental disorder. They completely have no understanding of why people will be concerned about their mental health. They can make no sense of the risk that is involved. And in such cases, the use of the Mental Health Act may be applied, where somebody is admitted into hospital under the Mental Health Act. But most patients are admitted to hospital informally, meaning that they do not require the use of the Mental Health Act. And in such cases, it's because A, the risk is considered to be low. Two, they have an understanding that they are ill and they're prepared to accept treatment. And in those cases, an assessment of their mental capacity is made, that they're able to understand and retain the information, and they can process the information that's been given to them. And when that is done, the patient can then be admitted into hospital and be offered treatment without the use of the Mental Health Act. So I've brought up this slide very quickly just to talk about a little bit about the Mental Health Act. The Mental Health Act, the current Mental Health Act came into effect in 1983 and is a piece of legislation that covers the care and assessment of patients considered to be suffering from a mental disorder, and it allows for their reception into hospital. Although the act itself was introduced in 1983, it got amended in 2007. It provided a different definition for mental disorder. Previously, under the act, the mental disorder was classified into 4 parts. It included mental illness, it included personality disorder, mental impairment, and severe mental impairment. But following the amendment in 2007, it's been made very simple that it's just any disability of the mind. So all the split into 4 no longer applies. And each chapter of the act is referred to as section. So some of us may sometime hear that, oh, it's been detailed under section 2 or section 3. It simply means it's a chapter of the Mental Health Act, and they are referred to as section. So section 2, this is a section that allows for compulsory admission of a patient to hospital for a period of 28 days. A patient has a right to appeal their detention. So again, this is section 2. Section 3, it allows for the compulsory admission of a patient with mental disorder to hospital for assessment and treatment for a period up to 6 months. It doesn't mean the patient needs to stay in hospital for 6 months. What it means is that if the patient improves at any stage, the patient can be discharged. For someone to be put on section 3, the nearest relative would need to be consulted. If the nearest relative opposes the section, it will not go ahead. And also for people to know, if a patient is detained on section 3, the nearest relative can appeal, can ask for the patient to be discharged, and the patient will be discharged. So I know that some of our folks often say that we're detained, that a lot of African Caribbean mental individuals are detained under the Mental Health Act illegally. The nearest relative has a right to apply for discharge when the patient is detained on section 3 if they don't agree to it. Okay, there is also what we call the community treatment order. If somebody's been admitted and discharged, if somebody's been admitted to the hospital and they suffer from a mental disorder, they can be made subject to the provisions of the Mental Health Act while they continue to live in the community. This is just a framework to provide care for a patient who is detained under the Mental Health Act, but the care will continue in the community. It can last for a period of 6 months, and after that, another 6 months, and then it is renewed annually. There are often conditions which are attached to the use of the community treatment order, which the patient must comply with. We call them mandatory and non-mandatory conditions. Okay. So this is the last slide. Once a patient has been to hospital and they've received treatment, obviously it's important that we are able to recognize people who are suffering from a mental disorder very early on. This is key because we know that the sooner they start treatment, the better the recovery, but also the better the prognosis. The longer it takes for someone to receive psychiatric treatment, the more difficult and the more the worse the outcome for that individual in terms of their prognosis. If somebody's been started on medication, it's important that they stay on the treatment that they've been started on and to have the conversation with their doctors on how long they should carry on with the medication, what side effects are they experiencing, and if they get to a stage where they think they want to start withdrawing or stopping the medication, it's important to have that conversation with their care team. Usually, when someone's been admitted under the Mental Health Act, they will be entitled to what we call an aftercare package. An aftercare package will look into their social care needs and their mental health needs, and it will be funded by the government, the local authority, and the healthcare. So if somebody has been discharged from hospital, they will have a care team around them that will support them even when they leave hospital, and they will continue to outreach them during their recovery phase in the community. As I mentioned earlier, to receive optimal treatment, medication is involved, sometimes talking therapy is involved. There's also family support that's provided to family members. There's what we call psychosocial support, and also information and education to the patient and the family of the patient as well. Again, the care package will take into consideration the patient's current social network and social support network. It will look at the living conditions. The aim will be to try and provide for the patient a meaningful occupation after they leave hospital, and they will be encouraged to maintain a good physical health state. These are all things that might be provided on discharge from hospital. So I'm aware that I want to bring this to a close so that we may leave room for discussion. So really, the take-home message from this talk is that we should pay attention to our mental health. it's important that we maintain a healthy mental health. And just because we have a mental disorder does not mean that we cannot attempt to continue to maintain a healthy mental health state. We should be alert to early signs of mental health problems. And in some cases, especially if we've previously had a diagnosis of mental disorder, we can have what we call an advanced directive, whereby when we get better and we've improved, we can actually write a document to let people know how we want to be treated, sort of treatment we want to receive, the hospital or the environment in which we want to be treated. And again, all of this will be taken into consideration when care is being provided. And of course, it's important to be able to seek professional help early and to engage with mental health services when it's available. So this, I will stop here. So I will stop now just to take questions. I'm aware that maybe I've gone a little bit beyond the time. Thank you very much for listening.
Thank you very much, Bodun. Do you want to stop sharing your screen so that we can see you?
Yes, how do I do that?
That's fine. I think you've stopped sharing your screen now. Thank you so much.
Okay.
That was a whistle-top tour through mental health, really. That was really, really interesting. And there are lots and lots of questions, So thanks for leaving some time at the end so we can address some of these questions. So one of the questions that we put, I think you answered this one. I think this came right at the beginning of the talk. It's about access to talking therapy. And you've said that it seems to be freely available on the NHS. You just have to ring up.
Yes.
This hasn't been affected in terms of access by COVID, has it? Because so many services have been affected by COVID.
Absolutely. Yes, it depends on the region, but the hope is that with the lifting of the COVID lockdown at the moment, individuals should be able to access services a bit quicker than they used to during the lockdown. It's freely available, and each region has phone numbers that you can contact in order to access, and you don't need a GP to do so. It should, by law, be able to, they should be responsive and be able to attend to you within 6 weeks.
So who's the they? So if I wanted
to
ask—
They are psychologists. They usually, people who are trained. Talking therapy assume that you don't, not necessarily, well, the talking therapy is based that there is an understanding that your illness is, your condition is based on psychological problems. And they don't usually use medication. And
so if someone's listening here today and says, that sounds great, I would really like to talk to someone, what do they do?
First of all, depending on where they live, the area in which they live, they can either Google that I live in so and so area. I need the phone number of IAPT in my area.
IAPT.
So,
IAPT
is IAPT. IAPT.
Okay.
So they will ring and say, I want to speak to someone. And then the person will then ask them what's going on.
Okay.
And then they would then schedule an appointment for them.
Okay.
And then they would then start the process.
That's excellent. That's really nice to know. So thanks whoever put that question in. That's really good. Now, one of the other things that struck me and has struck quite a number of people in the questions is that lots of the things you're describing say that you need to go into their background and all the things that might influence. I think some of the concerns are that if you have a white psychiatrist that might not understand the cultural and religious basis for some of our beliefs, that might not be taken into account when they're assessing our mental state. What do you find in your practice? Because the other thing that you put down, I wrote it down, was that we are 7 times more likely to have mental illness as Black people.
7 times more likely to be diagnosed.
With
psychosis.
With psychosis. Does that mean we have it, or that we're more likely to be diagnosed?
And that is where the question, and that's been the debate that's been going on for some time.
So is that because say that I believe in something that's very culturally Nigerian, that this is taken as some kind of psychosis because they don't know what it is?
Ideally, when one is diagnosing psychosis and one is diagnosing a specific, when one is eliciting a specific condition, symptom called delusions, delusions are abnormal beliefs which are held rigidly, but it's not in keeping with cultural beliefs. So if, for instance, you mention to someone something that is culturally appropriate for you, it should not be considered a delusion. It should not. But having said that, the diagnosis of a psychosis is not based on a single symptom.
Okay.
It's a clustering, as I mentioned. It would affect the person's thoughts. It will affect the person's behavior. It will affect the person's mood. And it will also affect the person's perception of the world around them. So if, for instance, you believe that you are from royal descent in Nigeria,
absolutely,
and nobody here can argue against that, and you may be well right in saying that, and you may be right, nobody believes that, but if you start telling that to, let's say, a doctor who is Caucasian, who may be thinking, oh, maybe that may be a delusion, he's not going to base his diagnosis purely on that. He's going to look at so many other things.
Okay, so it's some of the problem that they take that kind of thing into account, though, because someone's put as a question, I'm going to read it out because it actually summarizes the concern. It says, as Black people, we tend to spiritualize mental health. How is this considered or recognized in training or practice?
I think that is a very valid point. Absolutely, we do. And I think we recognize that there are what we call, there are charity organizations which work very closely with mental health services. And we know that especially Africans or Black Caribbeans tend to benefit when you have these charities, which obviously may, as for instance, we have a Christian group that comes to my unit, and we try and identify patients who might want to use them. Again, we encourage this, and it takes into consideration their spiritual beliefs and all of that. But the reality is that when somebody is ill, apart from their spiritual belief, there are other markers of illness that we look at. And as I mentioned earlier, any condition that is not associated with personal distress or associated with any level of loss of functioning, it's not a mental disorder. So for instance, I can believe what I want to believe. I can say I'm Jesus, for instance. I'm sorry for that. But if I say that and I'm happy, I'm working, I'm not, and I know who I'm saying that to, it doesn't, I want to be like Jesus. I guess what I'm saying is that there has to be a level of personal distress. There has to be a level of loss of functioning, either at work or in family life, and all of that for it to be considered a mental disorder. If that isn't present, then it's not.
Okay, that's nice to know, because some of those symptoms you were reading out, I was thinking to myself, I recognize that. I recognize that. So it's good to say that if there's no loss of function, then you're probably not diagnosed, because during lockdown, people have had a range of symptoms. And some of the lists that you had about the depressive symptoms, I know that there are lots of people that will be looking down that list and thinking, I recognize those symptoms. But the difference you're saying is that when there's sort of loss of function involved as well.
Absolutely. Can I just clarify that again? There has to be, there's a time duration into any of these symptoms. I just didn't want to go into details with that. For instance, with depression, the symptoms that I've listed there have to be present for at least a minimum of at least 2 weeks. And the mood changes have to be pervasive. So not just, I feel sad and depressed now because I've got my blood result or I've got my exam result and it's bad. No, even in pleasant situations, they are not able to react to the environment and be happier. They tend to find themselves flat consistently in all situations, and it then extends beyond a certain time period before a diagnosis can be made of depression.
Okay. So another question is about women who've just had babies. And first of all, we've got the prevailing circumstances of what's going on at the moment. So you're quite isolated. in previous years, you meet up with friends who've all had babies. So what they're asking about, some questions about how they can recognize the signs if they have postnatal depression, for example.
We know that, first of all, we know that the birth of a baby is associated with changes in the individual's hormonal system. There are changes to their lifestyle, and they have to make adjustments. So we know that there's what we call postnatal blues, which you don't require any treatment for. People tend to recover. About 5% of people are thought to people who have just given birth to experience postnatal blues. However, we also know that some people, for some reasons, are particularly at risk of developing what we call puerperal psychosis or significant mood disorders. Again, usually, what they experience is beyond what we would normally call just mild symptoms of depression. They are a lot more severe, and there's a lot more significant impairment in functioning, and there's a lot more personal distress that such individuals experience. Again, all the symptoms that I've mentioned in relation to thoughts, their thought pattern, and their thinking tends to be relevant. For instance, they may feel that they are not bonding with the baby, even though they've just had a baby. This is the early days. They're not able to be reassured by the fact that it's a process and it takes time. Again, nothing you say, they become extremely distressed sometimes, and they cry a lot, and the crying doesn't seem to abate, and it can carry on. They start feeling very self-conscious and start having very self-negative thoughts, that they are a failure, they're a bad mother, and this again carries on. It doesn't stop. They stop eating, they become very restless, agitated, and again, that can carry on. So I think it will be noticeable. This is a change. It's not just an everyday kind of thing. Because they are not easily reassured. So this is definitely something to be taken seriously.
So for people out there who are maybe watching and they think, oh, I've got a friend who's just had a baby, or a partner who has somebody who's just had a baby, and there's this change, what can they do? What sorts of things?
Well, the first thing to do would be, first of all, obviously the presumption is that there's somebody there that can provide support. I'm guessing that they will have the midwife still visiting in the days after. That's something that the midwife is likely to pick up anyway, provided that maintain a contact with the midwife. But let's assume that the midwife isn't available. Let's assume that, in fact, there aren't any relatives or parents. The first thing to do would be to contact the GP, if we know who the GP is. We contact the GP. But if that fails, because I can imagine that the GP, this person might not even have a GP, or in worst case scenarios, this person might not want to go to the GP.
Or if you have one, you ring up and they say, we don't have any space. That's the problem. Okay. I can tell you that. If anybody here tried to contact their GP recently, they'll first of all, you listen for 5 minutes to the, don't ring us if it's a vaccine you're ringing about, press 1, press 2. And by the time you get to the end of it, they say, we're only seeing people that are urgent.
Okay. And I know that is possible. Like I said, again, anytime anyone steps into a GP, if you go to A&E, you can go to A&E, you can walk through any A&E. There is always what we call the PLN in most A&E. PLN are psychiatric liaison nurses. In my trust, we've got that. We've got the psychiatric liaison nurses. We've got what we call the first response services in my trust. So the first response service is available. You ring them up, you Google the number, you ring them up, and you say, so and so is happening. They will send someone to you. If you don't want to go to A&E, again, through the first response services, they have what we call the home treatment service. The home treatment service, again, these are people who are linked to the hospital, but they will come home to see you. So you are struggling to see your GP, you Google the number. Again, for each region, it's different. But each region has a home treatment service. So they are hospital-based, but they will come home. So they are usually staffed by nurses, social workers, and sometimes support staff. So you either ring the first response, or you ring the home treatment service, or you go to A&E if you are having no luck with the GP. And then they will come and assess, and then they will determine what needs to happen next.
That's great to know. Now, I saw a study the other day that was really interesting to me. It was a study done in America, And it said that if you were a baby, that if you had a Black pediatrician, you are much more likely to survive. Are there any similar stats with people presented with mental health that have Black psychiatrists? So if I'm a Black person who has a problem and I present to a Black psychiatrist, does it have any impact on my outcome? Because I feel that there must be something that means that you understand maybe the way I'm thinking much better. You're able to understand my cultural beliefs and my religious beliefs better. Has there been any studies to look at that kind of association?
What I do know is I cannot recall any study that has been done specifically to look at the outcome for patients with mental disorder in terms of who they get to see. I'm not aware of any particular study that's been done to look at it. However, what I can say is that when I've had patients who have come from similar background, which is quite interesting. It's a funny one, and I can't, I mean, this is just a personal experience.
Personal experience, yeah, that's what we're here for, yeah. Personal experience.
It's a personal experience. When they've been female, they've been a lot more receptive and more engaging and more accepting and a lot nicer, and they tend to improve better and quicker.
So Black females? Black
female. My experience has been the opposite with male. They tend to be quite rejecting, very suspicious, and I don't know why, but I think that's the pattern that I've seen. I'm yet to come across, at the moment, I do work in the inpatient unit, so my experience has been pleasant, but we do undertake mental health assessment, and I've worked in the community as well, where I've seen patients in the community. Now, that could be for a variety of reasons. Obviously, if I'm undertaking a mental health assessment of somebody who is psychotic, in the sense that they're experiencing psychosis, the nature of their symptoms are different. Obviously, by nature of their symptoms, they tend to be suspicious. They tend to be irritable and aggressive sometimes because of their condition and the symptoms, and that tends to translate in how they interact with me. So that may be purely the reason, but in situations that I've had to manage on the ward, my patients, female, they've been a lot nicer and pleasant, and I think the outcomes be a lot better for them as well. Okay. I think there's a valid point that in terms of cultural background has a bearing on how nurses, perhaps support staff, and everyone interprets their condition, their symptoms, yeah. And perhaps doctors as well.
So maybe that's a study waiting for you to do, Dr. Bodun.
Well, it will be considered.
There's another question here about the tendency to overprescribe medication to Black people as opposed to talking therapies. That's the perception. And I also have that perception that we are much more likely to be diagnosed as having psychosis and schizophrenia. So as a psychiatrist, and when you were training, why is this? So it's either that there's something inherent in us that means that this is how we are, or that there's no difference, we're just being overdiagnosed. So I know you did some training in Nigeria. So when you compared the rate of diagnosis here in the UK as opposed to the rate of diagnosis in Nigeria, for example?
It shouldn't be, because the training is similar. But I think there is, I think if I remember correctly, during the early days of the lockdown, there was a lot of talk around what could be offered to support the training of trainees to be able to recognize culturally appropriate behavioral responses that sometimes are misdiagnosed. And there was a lot of talk around that.
So do you think that it's overdiagnosed in Black people?
Well, some studies have shown it. And I know that some studies have also shown that the mental, that people who are detained, a lot more people are detained under the Mental Health Act.
So what can we do?
Well, I think it's
someone here, because remember you talked about they have to get permission from somebody else. I think you called it a particular name, from somebody.
Nearest relatives.
Yeah.
Which is like next of kin.
The next of kin. So
yeah, really called nearest relative under the Mental Health Act.
So the next of kin means to be more aware, because although we want to help, we don't want to have family members being detained unnecessarily?
I think that's something that perhaps people they were not aware of before, which really they should be aware of. If, first of all, under the Mental Health Act, there's a right of appeal. Anyone can appeal that section. It doesn't matter. The hospital authority have a right to allocate, and they don't pay for it. It's an independent body that pays for a solicitor. So you have a right to appeal. If it's a section 2, which is a 28-day period, you can appeal. The moment you write, you say you want to appeal, it will be heard within 7 days. That's for section 2. But for the longer section, which is section 3, which is for a period of 6 months, when the application for detention is being made, they need to consult with the nearest relative, the next of kin. They have to by law. Okay. That consultation needs to take place. If the nearest relative say they oppose it, they don't want it, it will not go ahead. Okay. But it doesn't mean, say for instance, let me give you an example. If there's somebody who is poorly, and I don't agree, I'm the cousin or the brother, and I don't agree that they are poorly, and the social workers come and say this man needs to be detained, it will be around the risk. And the social worker tells me they want to detain this person. And I say, no, I don't agree that they need to be detained. In order for them to go ahead with that detention, they can't go ahead with it at that moment. In order for them to go ahead, they will have to apply. They will have to apply to the courts to get me back as the nearest relative. But the conditions that they need to satisfy to ensure that happens is what we call dangerousness. So they have to be able to convince the court that this person is an imminent risk, not just a potential risk. This person is at a point where they're going to do something dangerous. They're going to kill somebody, or they're going to kill themselves, or they're going to cause havoc. They have to prove to the court, and it's so difficult to be able to establish dangerousness that often the application will just not go ahead. So, and also the other bit again that I need to emphasize, if somebody is detained under section 3, let's say they've been in hospital for 4 months and you're not happy with it, and you as a nearest relative, you can apply to have the person discharged. Okay. And again, the same thing would apply. The same condition needs to be met for the hospital to say they don't want you to do so.
Okay. So that's important, because as relatives, what you want your relative to get better. So you'd only be making these applications if you know your relative and you don't actually feel that they're as ill as the hospital or the service is making them out to be. So that's really important information. There's another question here about treatment. And is it that you have depression as a particular diagnosis, mania as a particular diagnosis, schizophrenia as a particular diagnosis, such that the question is that if you don't treat mania, can you then go on to develop schizophrenia? Or is it like saying that if you don't treat diabetes, you can go on to develop cancer? Are they two different things? Or if you leave depression and mania untreated, do you then become schizophrenic? Okay,
all right. Again, the thing I need to make, first of all, the answer to the first question is this. Depression, a depressive episode, is a separate diagnosis. Okay. Mania is a separate diagnosis. Bipolar is a separate diagnosis. I've grouped them together because they fall under the group which we call affective disorder, the mood disorders. Now, the thing I need to explain is this. If somebody has a diagnosis, has suffered from depression in the past, and they then experience a manic episode, a mania, we call it bipolar. That's what it is. Bipolar simply means is alternating mood state. So they've had depression in the past, now they're experiencing a mania, or maybe
in between the two, in a sense.
Yes, alternating between the two is called bipolar. That's simply what bipolar is. However, there must be a period of relative wellness between the two episodes. Let's say in January they had depression, maybe in March they then had the manic episode. But between the two episodes, there's a period of relative wellness. It shouldn't be the same continuous episode. The answer to the question as to whether they can suffer psychosis Schizophrenia is a form of psychosis. I've just used schizophrenia. I could have used delusional disorder. I could have used drug-induced psychosis. So it's just a form of psychosis. Each condition like depression or mania can become psychotic, can be complicated by psychosis if it gets severe. Say somebody's had an untreated depression and the depression carries on. These beliefs around, oh, I'm hopeless, life is dangerous, my body isn't working. It can then cross from those being abnormal beliefs, negative beliefs, to become a full-blown delusion, where we now say, yes, this is a psychotic depression. But it doesn't mean they will meet the criteria for schizophrenia.
So schizophrenia is a separate diagnosis.
It's a separate diagnosis, yes.
But it's important to treat the depression when it comes along so you don't have psychotic depression.
Absolutely, absolutely.
Thank you. Well, I have really gained as usual, and thank you so much for coming. I'll just check to see if there are any further questions. Oh, there's another question here about habits and lifestyles. If you have schizophrenia or some of these illnesses, are there particular habits and lifestyles that can reduce the or improve the impact of these conditions that you don't need medication? And I'm sure you mentioned that when you were in your talk about the importance of a healthy lifestyle.
Absolutely. I think no matter what the diagnosis is, no matter what our condition is, whether we have the condition or not, it's important to maintain a healthy lifestyle. And the simple analogy that I will give is a physical health. To be physically active, we have to do, to be physically well, we have to do certain things. We pay attention to early symptoms, we exercise, we try and sleep early, we try and manage situations that we think potentially might make things difficult for us. We avoid the abuse of illicit substances because this has an impact. This, no doubt, would impact on how our body functions and also how we react. So those are healthy lifestyle. And I think even if somebody has a diagnosable mental illness or a diagnosable mental condition, if they engage in all these habits, exercising, sleeping on time, avoiding abuse of substances, maintaining routine, getting involved in routine, activities that would that they feel happy with. It's important to schedule activities that we particularly find enjoyable into our weekly routine, and not just work, things that we particularly find enjoyable. And all this is the risk of relapse will diminish. Even if somebody had a diagnosis of schizophrenia or even depression, the risk will diminish. And of course, to remain engaged with services.
This has been a fantastic session. I knew it would be. And thank you so much for giving up your time. I say this to all our doctors each week, but this in particular, because I know a lot of people had contacted us for a session on mental health. So this has been particularly important and particularly enjoyable. And thank you so much, Bodun. Thank you so much. It has been excellent, fantastic. So I'll just say that before I hand over to Faye, in response to some of your suggestions that you've been sending in, next week we have Dr. Stephen Okoli, who's a consultant hematologist at Imperial Healthcare, coming to talk to us about sickle cell. So I know we've had a lot of questions about that. And the week after, keeping to the mental health theme, we have a session on dementia. I'm really pleased to invite Professor Uduak Archibong, who is the Pro Vice Chancellor of Bradford University, who's going to give a sort of introduction. And then we have another psychiatrist, Dr. Mercy Ochukwuemore, who's going to talk to us about how to diagnose dementia, which is, again, quite important. As you know, we have a lot of health issues relating to our kidneys. We've got a nephrologist coming, Dr. Chris Agbo, on the 22nd of May. And lastly, we have on the last weekend of May, a consultant maxillofacial surgeon, Dr. Robert Goddard, who's going to come and tell us about maxfax problems and their treatments. So an exciting May. And again, thank you so much, everybody. I'm going to hand over to Faye.
Thank you, Ngozi, as always, for facilitating such a fantastic session. I just want to say, Dr. Bodun, that was fantastic. It was really, really important. And we talk about mental health and the mental health of Black people in particular on a regular basis. So that was so enlightening. I think we need you back again. I think I'll be really looking forward to a session that focuses on culture, religion, race and mental health. I think we really need something like that as well. So I look forward to negotiating that with Ngozi and yourself.
Absolutely.
So
we have lots of repeat performers, so that's great.
We do. Yeah, but absolutely fantastic. Thank you. I just want to finish and let you all go because I know we've run over. Just to let you know, Charles isn't here doing this because we're packing vitamin D. So if you live in the city of Manchester and you want to distribute vitamin D to your members or service users, please get in touch. I think there's information in the chat box there for you to access how to do that. But Ngozi has gone through all the different things that we've got coming up. Dr. Bodun as well as mentioned healthy lifestyle. So we say this every single week. Please come along to our sessions on a Tuesday and on a Wednesday. We have physical activity and we also have nutrition as well. So please come along, get yourself healthy. We're all coming out of lockdown now and we all want to look our best and feel our best. So please come along and join in. The details are in the chat box. So all I would like to say now is enjoy the rest of your long weekend, bank holiday weekend. Let's hope it doesn't rain on Monday, and enjoy the rest of the coming week. So thank you again for participating.